Hello, everyone, and welcome to this edition of Saliva Direct Inc.'s webinar series. We're very excited to have so many people joining us. And while we wait for additional individuals to find their way over to us on the link, I'm going to offer a little bit of an introduction. First of all, for those of you who don't know me, my name is Brittany Choate. I'm Director of Programs with Saliva Direct Inc. We are a nonprofit dedicated to enhancing public health through accessible testing strategies. Our team works to develop and deploy innovative solutions that respond to evolving global health challenges, and by providing more equitable testing solutions and hosting events like this one, we hope to promote, advocate, and advance patient-friendly diagnostics. I'm joined today by my colleague, Victoria Hurley, who's our team's marketing manager. She's going to be helping keep track of the chat and overseeing live updates. Thank you for joining us, and it's my pleasure to welcome you to this edition of our webinar series. On today's webinar, we are joined by Dr. Mark Schleiss and Jack Heisel. They'll be discussing the power of saliva, revolutionizing congenital CMV newborn screening, and how saliva-based diagnostics and digital health infrastructure can improve early detection and access to care.
Thank you, everybody. I really appreciate the opportunity to be here today and to talk about cytomegalovirus and ongoing changes in the space of newborn screening for CMV. So I'll talk a little bit about some of the work my lab has done in that area, some of the advocacy and public relations work that we did to codify universal newborn screening for CMV in the state of Minnesota, and then some of the applications of research questions about pathogenesis of congenital CMV that we're trying to get at using saliva samples. And so in terms of the flow, I want to really focus mostly on detection of CMV and talk about the pros and cons of using saliva-based platforms versus other approaches. And then as time permits, we'll talk a little bit about pathogenesis and how we use saliva as a tool to try to interrogate that. And then maybe just a couple of minutes about the current landscape for CMV vaccines. But we'll focus on detection. And newborn screening of CMV is a little bit like looking for a needle in a haystack in some ways, because we don't really know in any given newborn whether or not we're going to find the virus based just on clinical clues alone. The textbooks talk about the classic findings of congenital CMV as being a symptomatic infection, but the virus is a very stealthy virus. This is just what the virus looks like schematically. It is a herpes virus, so it's one of 8 human herpes viruses that includes chickenpox and herpes simplex. And in CMV, we have focused on these kinds of babies over the last several decades, really over the last century, because congenital CMV was first described in the late 1800s. Long before viruses had been formally detected, there would be occasional births that would have what was called a blueberry muffin rash. Babies would be small for gestational age, would have unusual skin lesions and findings. And we know now that when the virus was formally discovered and dissected in the 1940s and 50s and 60s, we know now, of course, that this is a herpes virus, an enveloped double-stranded DNA virus. And it's the most common infection, not only in the United States, but probably in Europe and throughout the world, that causes disability in children. So when I sort of use that as a talking point, that carries a lot of weight to think about which infectious disease is actually most commonly responsible for disability in children. And so CMV can cause hearing loss. That's the major disability associated with CMV, sensory neural hearing loss. It's responsible for about 25% of all deafness in children. And the challenge with that is that a baby can be born with normal hearing and have CMV infection, and that baby can go on to lose their hearing by 2, 3, maybe even 4 or 5 years of age. And so it's a progressive process. And so often I'm asked, well, we screen all newborn babies for hearing loss. We have universal newborn hearing screening. Why don't we just rely on that? And the answer is that much of the hearing loss is delayed in onset. And so this just shows the magnitude of the problem. Overall, about 13% of all babies born with CMV will go on to have hearing loss. And that hearing loss is sometimes delayed in nature. In the United States today, we have somewhere between 20 and 40,000 babies born with CMV out of a birth cohort of about 3.9 million. And 80 or 90% of those babies seem normal at birth, but 12 to 15% of those babies can go on to have delayed hearing loss. And there are other pathologies, neurodevelopmental disorders, learning disabilities, mental retardation that can also be inapparent until a child is in preschool or kindergarten. So how do we find CMV? How do we look for CMV? And should we be looking for CMV in every newborn, even the ones that are asymptomatic at birth? One often hears people, clinicians, talk about serologies, blood tests to look for antibody tests. There's an old acronym known as TORCH titers that some clinicians will still draw. But the key here is not to do antibody testing against the pathogen of interest. That's still pretty useful for some diseases like congenital syphilis or congenital toxoplasmosis. That's the one that a pregnant person can acquire by changing cat litter or eating undercooked meat. But for CMV, the answer is looking for the virus and not the antibody response to the virus. And newborn samples are really a key, and I'll come back to this repeatedly in my remarks, this notion that you can wait and see and always circle back and test a baby for CMV in the first couple of years of life is a major knowledge deficit issue that we need to address because babies will get CMV after birth. It happens a lot from breastfeeding. They can get CMV from their siblings. They certainly get it in group daycare centers. Toddlers in group daycare centers, children under 3 years of age in group daycare, up to 70% of those children will get a CMV infection in a group daycare center. And so you have a child who may have delayed onset hearing loss and developmental delay, comes in for a 2-year-old checkup. That baby's tested for CMV. The CMV test is positive. People think, oh, there's the answer. No, that's not the answer because that may be a postnatal acquisition. So we really need to test in the newborn period. This is very much an issue of newborn screening. And so the babies that we see with the blueberry muffin rash that I showed you a moment ago, they're just the tip of the iceberg. And you've got this giant iceberg below the surface of all these babies with clinically inapparent CMV infections. So what do we do with those babies? Well, this is the incidence data. About 1 in 200 births are affected by CMV. And when we think about screenable disorders like phenylketonuria or SCIDS or galactosemia, we know that those are incredibly rare disorders. And so this is actually the most common of all of the screenable disorders. But again, the dilemma is the majority of babies actually have a good prognosis. And so does CMV actually fit the classic criteria? And how do we screen? Some experts will advocate hearing targeted screening. In other words, look for babies that fail their newborn hearing screen and then limit CMV testing to just those babies. And that has been codified and it's actually practiced in some states in the United States. Utah was the first state to start this, maybe 15 years ago now. The challenge there is, as many of you know, most babies that fail their newborn hearing screening actually can hear just fine. There's a very, very high false positive rate, and that's okay. In any screening test, you don't want to miss a case, but 1 to 5% of normal newborns in a normal newborn nursery will refer on their newborn hearing screen. But the prevalence of hearing loss in babies is only about 1 to 2 per thousand. So obviously the vast majority of those babies don't have hearing loss at all. And so we do detect some babies with congenital CMV who refer on the newborn hearing screen, but I've become convinced that we should be doing universal screening for congenital CMV because that will detect all babies with CMV-related hearing loss that occurs in infancy and early childhood, even the babies that don't have hearing loss yet at birth. And that was very nicely shown in this study by Karen Fowler in the CHIME study in the early 2000s. They did a study of 100,000 babies, and found that about 45% of the infants who had CMV-related hearing loss were not identified in the newborn period. That's because they didn't have hearing loss at birth. They went on to develop hearing loss later in childhood. And so the only way you're going to capture those is universal CMV screening, because if you find an asymptomatic baby with congenital CMV by universal CMV screening, then that's one that you'll flag and say, look, you've got to come back and get an audiologic assessment. How often is a matter of some debate. Personally, I recommend every 3 months for the first 3 years of life and then reassess. But if you rely simply on babies that refer on the newborn hearing screen, you'll miss about 45% of all of those infants who do have congenital CMV-related hearing loss. And you'll deprive them of the opportunity for early intervention, correction of hearing loss with hearing aids or cochlear implantation. That in turn will deny them the opportunity for normal speech and language development. And in some cases, you'll deny them the opportunity for antiviral therapy. So a lot of babies are not identified by hearing screening. So I'll spend the rest of this time talking about universal screening because in my opinion, it is the preferred public policy pathway, but this is an area of continued debate and discussion. And again, the key point with universal congenital CMV screening are the 80% of babies who never seem to have any long-term disability. So what do we do if we include congenital CMV in the universal screen? If we fall into the category of, yes, this is good public policy, we follow anticipatory management, serial hearing evaluation, that's the key. Some people say, though, that we might overuse antiviral medicines inappropriately. And the big one is footnote D on the right column, the undue parental anxiety. There is concern that by identifying congenital CMV in babies who are destined to have a normal outcome, that we may be promulgating a syndrome of a vulnerable child who is at risk for other long-term health consequences incorrectly. So this so-called vulnerable child syndrome is very much an ethical concern. The recommended uniform screening panel, or RUSP, derives much of the principles from the sort of classic monograph by Wilson and Younger in the 1960s. And key to this is the idea that you would have some kind of a good screening test and that screening test is adequately sensitive. And so this now segues into the next part of the discussion, which is the issue of, do we have an adequate screening test in the newborn infant? And the CHIME study that was done in the early 2000s and published in 2010, 100,000 babies in geographically very diverse collection of newborn nurseries around the country, showed that the dried blood spot, which had been advocated as a particularly useful screening modality for CMV, only had a sensitivity in the 28 to 34% range, whereas saliva PCR had a very high sensitivity. And these studies all used a urine cytomegalovirus culture as the gold standard for diagnosing congenital CMV. So for a decade or more, saliva-based PCR was the focal point of discussion, policy discussion in the newborn space. And this was really the dogma in the field. So I began to think about this issue quite seriously in the early 2010s because all dogma should be challenged once in a while. And what we saw in the last 15 years were very striking improvements in DNA recovery. You get an infinitesimally small amount of blood from a couple of punches out of a dried blood spot card, but enhanced techniques of extraction and recovery of DNA, published by Kuntz et al. At the CDC, sort of led us to a hypothesis that to ask whether or not it was worth revisiting the dried blood spot. And so I commenced a study in 2016 here in Minnesota. We decided to look again at the sensitivity to dried blood spot. And we looked at about just under 25,000 babies over a 6-year period. And my gold standard in the study was saliva. So we did saliva swabs on all newborns, and we compared that to the dried blood spot. Again, the rationale for this is that the dried blood spot is already collected. It's a part of a, infrastructure that exists. It's available, and the most expensive thing, obviously, in healthcare in the United States of America is the cost of somebody's time. And paying somebody to collect saliva swabs on every newborn, or heaven forbid, a urine sample on every newborn, is so onerous when the dried blood spot is a routine standard part of newborn care. I really felt that this needed to be looked at again. So here we are in Minnesota, Paul Bunyan, the northern Canadian border, and these are the newborn nurseries here in Minneapolis and St. Paul that we looked at. And I also looked at a rural nursery in the northwestern part of the general Twin Cities area. And the dried blood spot was processed, DNA extracted, and I looked at, in my lab, I've optimized what's called the UL83 gene, which is a gene that encodes a phosphoprotein. We also collaborated with Sheila Dollard at the CDC, and she looked at the immediate early gene. And we found, in contrast to the CHIME study, that the two dried blood spot methodologies actually brought back a sensitivity for detection of congenital CMV of just under 86%. And so that was really a game changer, because the early CHIME studies done 15 years earlier had only found a sensitivity in the high 20s, low 30s, definitely not amenable to universal screening. We did occasionally actually have positive dried blood spots and negative saliva samples. Saliva was still the most sensitive test. It had an analytic sensitivity for detecting congenital CMV of 93%. And of the handful of children that had bona fide congenital CMV, which we confirmed, by the way, in getting a urine sample, we called every baby back that was tested positive on any of these assays and got a urine sample within 21 days of age. Those that were negative by saliva and positive by dried blood spot and truly had congenital CMV, we found that the real issue was there was so much DNA on the saliva swab that when we diluted it and repeated it, most of them did come back positive. But we couldn't report that because that was not the way the study design was set up. So this was the sensitivity of saliva versus dried blood spot. Now I want to call your attention to this slide, which is from the JAMA paper. And notice the red dots, which are all false positive saliva swabs. So these are babies that have positive salivas for CMV, negative dried blood spots, but according to the rules of the study, they were called back, examined, and had a urine sample obtained. And they were all negative for congenital CMV. So this is a example of what I think is the big issue with saliva. Many of these babies had gone to breast in the first few hours of life and had perhaps exposure to a little bit of colostrum, but that alone was enough to make their saliva swab positive for CMV. Being exposed to CMV positive genital tract secretions in the birth canal could also be a source of CMV in the saliva. Whereas in the dried blood spot assay, we only had one false positive test. So I think this is the challenge confronting the field now, looking at the relative sensitivity and specificity. Just a note of interest, we did also find that at least in our Minnesota cohort, essentially all of our babies were the second child born in that family household. And virtually all of them had an older sibling in group daycare. So if we talk about prevention and intervention and public knowledge and awareness about CMV, I think that's going to be a really important point to look at into the future. How did I follow up these babies? It was complicated because a lot of this was right in the middle of COVID-19. So I sort of seized the day and did the work myself, a lot of shoe leather, walking from one clinic to another, coordinating and setting up appointments, because this is a complicated evaluation. Most experts would recommend that a baby that tests positive for CMV, even if they seem asymptomatic and have a normal physical exam, which is most of them, should get an audiology assessment, should get a blood count, liver function tests, an ophthalmology referral, a head ultrasound, and then use that information to define whether they were symptomatic or asymptomatic. I didn't want parents to have to come back for 5 or 6 appointments, so I really doubled down on trying to do it all in a single visit. And these are the 4 criteria that I pigeonholed these babies into based on what I think is still the best reference, the Rawlinson et al. Reference from Lancet. This reference, by the way, is the one that the Red Book of the American Academy of Pediatrics Committee of Uninfectious Diseases uses for defining disease. And this is kind of a flow chart showing of the 87 infants that we confirmed as being positive for congenital CMV. That's prevalence of just under 4 per thousand, or 0.4%. Most of these babies classified in the asymptomatic category, although a couple of those babies did have late onset hearing loss. And so now that we have universal screening in Minnesota, this is going to be an important part of the future. Now, the other question I asked in a follow-up paper, and this was just published in JAMA Network Open a couple of months ago, is to compare the analytic sensitivity, that is to say, how often did the test come back positive for CMV in a baby that was confirmed to have congenital CMV by a urine test, and what was the clinical sensitivity? What was the ability of the test result to predict disease using that Rawlinson criteria pathway that I showed you a moment ago? And we found that the clinical sensitivity was actually 90% or greater using the more sensitive PCR primer pair. The clinical sensitivity of saliva, 95%. Again, that is the sensitivity or the ability of the test to identify a baby who's going to have some kind of a problem, symptom, or sequela from their CMV infection. But you can see that optimizing PCR primers yields a clinical sensitivity that should be as good as the saliva test. So where does this leave us? Is it the dried blood spot that we should be focused on the left, or is it saliva? Certainly ample sample here in this baby. Brittany brought up in her introductory remarks the issue of equity. And I think that's really an important one here. A baby that screens positive in the newborn nursery for saliva, where you can't collect a urine to confirm it before discharge, or a baby that refers on the newborn hearing screen that might have a spot saliva test that's positive. You don't know if that's a true positive. And it's not always easy to collect a urine sample. The bag falls off. The baby has a bowel movement in the bag and it can't be used. There's a myriad of reasons. Family wants to go home. And I'm very nervous about sending babies home if I don't know they're going to follow up. And I think that creates a real health equity problem in terms of follow-up. And the difference is that with dried blood spot screening, in theory, every baby should be identified because every dried blood spot is treated the same. I've already mentioned the issues of cost with saliva. You've got to pay for a nurse's time to collect that sample, and the issue with false positives, of course. And the timeliness of collection and processing of the saliva. Who owns the test? Is it the staff on the newborn nursery that will do that as a part of the hospital discharge, much as they would for a pulse oximetry check? Or does it go off to the clinical laboratory, which takes hours of processing, often creating a scenario where you won't have a result before the baby's ready to go home? Now, I will mention this nice paper in Nature Medicine last year from Dana Wolf and her colleagues in Israel. What they did, as you can see in the bottom part of the panel, is they pooled saliva PCR. So in a nursing ward, they might get 8, 10, 12 swabs and stick them all in a single tube and run that pool. If that pool is completely negative, then none of those babies have congenital CMV. If that pool is positive, then there's at least one baby in that pool that has congenital CMV. So then you can go back and do individual saliva tests or individual urine tests in that pool. Congenital CMV is rare enough that this is actually amenable to a reasonably high throughput and turnaround time. Healthcare is delivered differently in Israel than it is in the United States, though, and I've talked with Professor Wolf about this a number of times. In her hands, in their newborn nursery, they can turn this around and get this information back before the baby goes home from the newborn nursery. I'm not sure it's that straightforward in the United States. I don't know. I think we need to look at this. But I think right now, as we talk today, I don't think we really know what the best strategy is for universal congenital CMV screening, nor do we necessarily know if this is even a good idea from a public policy perspective. So, one of my hats that I wear is as a clinician. I am a pediatrician, and I have seen and taken care of these babies for many years. And I was talking with a family in 2016. Um, Her name is a matter of public record, little Vivian Henriksen and her mom. And we were sort of having a, gee, wouldn't it be great kind of moment where we were talking about newborn screening. And so Leah, Viv's mom, actually went down to the state legislature. And here's a picture of her and Vivian in front of our legislative building in St. Paul, Minnesota. And we talked to many, many, many representatives over a period of a couple of years to try to get a bill put together. And this involved a lot of lobbying and a lot of meetings and a lot of sessions with families. And it was a really very, very wonderful experience, actually. And in many ways, it kind of restored my faith in democracy, especially after some of the events in the United States in early 2021 that were deeply troubling to many of us here. In any case, this bill, after 6 or 7 years percolating through the legislature, making it to the governor's desk and getting vetoed one time, but it finally made it across the finish line. So we started newborn screening in 2023. This was another family, the Stidel family, little Hank, who was identified in my universal screening study. Very interesting case of a baby whose congenital CMV clinical manifestations were limited to retinal disease, which is very unusual. And so we began this as a matter of policy in 2023. It became added to the newborn panel. Here's a personal testimonial from Stephanie, which I've heard many times over the years. You know, my obstetrician told me about sushi, told me about cat litter, told me about undercooked meat, talked to me about listeriosis. But with rare exception, most of the moms I've talked to over the years who've had a child with congenital CMV weren't counseled at all about this. This was our representative Kelly Fenton and our state senator Karen Housley, who co-sponsored the bill in the legislature. This was a session where we got it through a committee, and this was the day we announced commencement of universal screening in February 2023. And this is some members of my lab team that really led the work that we were doing. So it was kind of two tracks in parallel. One of validating and showing that dried blood spots indeed were tenable and usable for universal congenital CMV screening, and then also the public policy work. I think we would have had newborn screening added in Minnesota even if I had never done any of that work in the lab. But the two factors kind of complemented each other. And so as of 2023, Minnesota was the first state. I need to update this slide now and color in Connecticut because Connecticut is now the second state by legislative fiat to have added universal congenital CMV screening to the newborn screening panel. New York State did it for about a year and a half or so as part of a pilot program funded by the National Institutes of Health, but they did not get it added to their universal program through the state legislature. So these are some of the clinical challenges moving forward. I won't belabor these points, but for those that are interested, I'm glad to talk more offline, and this continues to be a topic of some controversy. There are some infectious disease experts in the United States who don't advocate for universal newborn screening. Canada, on the other hand, now has several provinces, including Ontario, Saskatchewan, Alberta, I believe the Northwest Territories is next, who have all added universal newborn screening to their state or their national panel, which is very much province to province, just like in the United States. Newborn screening is often a decision process that's left up to the state laboratory. Quebec, on the other hand, interestingly, does not advocate for universal congenital CMV screening. We're interested in the neurodevelopmental outcomes of babies who are asymptomatic and look normal at birth. We've done some preliminary work suggesting that indeed, if the laboratory and imaging workup is negative, that these babies do well developmentally, but we need more data on this. Let me segue a little bit into saliva and the rationale for looking at the saliva samples. For one thing, I had 25,000 saliva swabs in my freezers, and I didn't know what to do with all of them. But I thought that it would be quite interesting to ask some additional questions toward the goal of trying to find a biomarker that might predict outcome in some of these babies, if in fact they went from being asymptomatic at birth to having some long-term neurodevelopmental outcomes. And lots of things have been proposed over the years. One study done by Soren Gant, which is the fifth bullet point down, looked at microbiome analyses in older children with CMV and found some interesting differences and correlated those with the prevalence of atopy in those children. But I thought, well, this is a very interesting opportunity to look at these newborn saliva swabs and ask about the microbiome. The goal would be to find a cluster of genes, as Pablo Sanchez found in blood samples from babies with hearing loss, late onset hearing loss, a cluster of genes that might be associated with the risk of sequelae, but to track that to the neonatal microbiome in response to infection with CMV, sort of an indirect effect of the virus itself. So we know that the early fetal microbiome is derived shortly after delivery from the maternal gut, from the maternal breast milk, the milk and skin, and there is vertical transmission of maternal, vaginal, and fetal microbiomes as well. But newborn babies do indeed have a microbiome at birth, and this is seeded by the maternal microbiome very commonly. And we know that that microbiome in the first year of life has a big impact on fetal immune response and on brain development. And so would it be possible that some aspect of the neurodevelopmental sequelae associated with CMV might be related to aberrant microbiome considerations in the babies that are born with the virus? And so we were sort of, that's kind of the long-term issue, whether or not that neonatal microbiome is correlated with neurodevelopment in these babies. But the short-term issue is to say, is the microbiome perturbed? So CMV is a very interesting virus in terms of its history and nomenclature. For prior to the 1970s or so, cytomegalovirus wasn't even called cytomegalovirus. In the literature, it was known as the salivary gland virus. That was like sort of its official name because of its propensity to live and thrive and probably establish latency. It is a herpes virus, and so it does cause long-term latency for the lifetime of the individual in the salivary gland. And so we were interested as a preliminary experiment to ask, looking at the saliva, were there changes in the neonatal oral microbiome? And so you saw this flow chart earlier. This identified babies that came from various symptomatic and asymptomatic clades in our universal screening study. And of these 87 infants, we did a pilot study in 6 babies looking at the microbiome in the saliva. And so reasonably straightforward experiments, so using 16S ribosomal sequencing, although lots of data to process. And so when we compared CMV positive salivas from babies with bona fide confirmed congenital CMV, not just transient colonization, but true congenital CMV, with CMV negative controls, we looked at the alpha diversity. That's a marker of the number of species within a sample. And CMV negative babies had more species present. Alpha diversity richness is a feature of healthy, normal development in babies who have a normal microbiome. So that's what the green dots in the slide illustrate. The red dots, on the other hand, less species richness. And so when we looked at a second parameter that's commonly employed in microbiome research, the beta diversity, that is to say, measurement of the dissimilarity among samples, you can see the green samples, the CMV negative babies, all cluster together very nicely in the lower right-hand quadrant. And so some people call this the Anna Karenina effect after the Tolstoy novel, that every happy family is happy in similar ways, whereas dysfunctional and unhappy families are often unhappy in very different ways. That's actually on the first page of that novel. And so the pink squares show the Anna Karenina effect, that is to say, dissimilar microbiomes, which is a feature of aberrant beta diversity. And so when we looked at the individual species level, there were certain species that were overrepresented in healthy microbiomes of CMV negative babies, but largely absent in the congenital CMV babies. And these were the top three species, two Clostridial species and a Collinsella species, that differentiated the microbiomes of CMV negative and CMV positive babies. So is it possible that someday, as a part or a component of universal congenital CMV screening, that one of the parameters that could be explored would be the microbiome analysis of the saliva of babies with confirmed congenital infection? That would be very intriguing, especially if you could link these aberrant microbiomes to adverse neurodevelopmental outcome, which is a goal that we'd like to pursue if we can find funding to do it. So the second point would be, in infants that fail to establish a normal oral microbiome because of the CMV in their salivary gland, could that be corrected with probiotics or some other intervention that could restore a normal homeostasis for these babies? That's incredibly speculative, and I don't have any data yet to confirm that, but I think we can say, at least based on this pilot experiment, that the babies that had congenital CMV do have a very aberrant microbiome. The other thing we did was a proteomic analysis, and CMV has a very immunomodulatory genome. It's the largest virus of any human pathogen, both in size of the particle itself as well, more importantly, the size of the genome. CMV encodes many, many genes that modulate the host immune response. And you can see some of the ones that stand out in this slide include complement proteins, IgG binding proteins, members of the immunoglobulin heavy chain family, and lactotransferrin. Transferrin is an antiviral component of breast milk itself. And so is it possible that in the presence of CMV, the viral genome is downregulating host immunity, in turn contributing to the aberrant microbiome, which in turn could impair normal neurodevelopmental outcomes? Incredibly speculative, but that was kind of our motivation. Well, I'll just end in the last couple of minutes and talking about vaccines against CMV. We live in a window in our history now of this incredible paradox of sort of the golden age of vaccine discovery at the bench and in the basic science lab, and the new techniques, new ways to express immunogens, some clinical data showing unexpected benefits of vaccine studies. A study a couple of months ago showing that adult recipients of the zoster vaccine have a reduced long-term risk of dementia. Studies that mRNA vaccination, it doesn't matter against what pathogen, that just getting an mRNA vaccine if you have cancer actually improves the outcome of your underlying malignancy, probably through upregulation of anti-cancer cytokines. And so on the one hand, we have all of this incredible new science on vaccinology in the public policy arena and political arena. We're losing ground in vaccines. We do need a vaccine for congenital CMV, as I've already alluded to. It is the most common infection that causes disability in children in the United States and probably globally. Vaccines have been, believe it or not, in testing in people for over 50 years now. but we haven't really found the right vaccine because we don't really know the correlate of protective immunity. We know that a pregnant person can get reinfected with a new strain of CMV during her pregnancy, even if she's got long-standing immunity. We know that viral strains vary from each other. Measles, there's only one serotype of measles, but CMV has, it's like snowflakes. No two are alike. And so reinfection can be due to strain variability. And so we really need to understand the relative contribution of some of the proteins in this cartoon. It is an enveloped virus like RSV. RSV is a very different virus, but we know that monoclonal antibody treatment of a newborn baby with an antibody that targets the proteins that stick out in the viral envelope can protect that baby from hospitalization with RSV disease or vaccinating the mother during that pregnancy. We don't know yet if those antibodies against those CMV glycoproteins on the cell surface can be protective in a vaccine or not. The other challenge is that around the world, how would you implement a CMV vaccine globally, knowing that in Egypt or Brazil, 95% of women of childbearing age have already had CMV, whereas in the United States, in a young woman of childbearing age, it's a coin toss, a 50-50 chance that she will have had CMV. Now, there is a rationale potentially for giving a vaccine to protect against those reinfections that I alluded to a moment ago, but implementation of CMV vaccine globally is challenging. Having said all that, these are kind of the products that are currently being evaluated in the United States. Most of them are based on protein or messenger RNA. The second study, the mRNA 1647, looked at a combination of envelope glycoproteins as shown in this cartoon. Like any mRNA vaccine, the RNAs encode for the protein, which is then processed and expressed and becomes a target of the immune response. The manufacturer in this study sponsored a very large phase 3 study and the results were just released a couple of months ago. And unfortunately, that vaccine was unsuccessful in that phase 3 study. So we're kind of back at square one in many ways with the CMV vaccine for pregnancy. Now, there's also a rationale for a CMV vaccine that would be given to people that required a solid organ transplant, somebody who was on a waiting list for a kidney or liver transplant, or somebody who was undergoing a bone marrow transplant for malignancies. CMV causes very serious disease in those populations. Although we have good antiviral drugs today to inhibit CMV reactivation, there is a study ongoing in the United States in liver transplant patients to ask if immunization can protect against CMV disease following the transplantation. And we may see in the next decade vaccines licensed that are very different vaccines, one that would be given to a woman contemplating pregnancy, and another that would be given to an individual anticipating a solid organ transplant. The immune responses that protect in those two settings might be very different, but we will see how the landscape emerges in the next few years. And for those that are interested, I put together a workshop at the NIH in 2023, and this paper was published last year that has all of the proceedings from all of the pharmaceutical companies around the world. We actually had really good representation there to talk about their CMV vaccine platforms. So with that, I will stop, and I appreciate the invitation to talk to you today. I've hopefully told you a little bit about the landscape for newborn CMV screening, the rationale for doing it, some of the controversies that are implicit in universal congenital CMV screening, the relative roles of the dried blood spot and saliva in terms of cost, sensitivity, specificity, and health equity issues. And in many ways, that's still an unresolved question. And then I've given you an example of how we took those saliva samples in my lab and took them in a different direction to try to identify a biomarker that might predict outcome in the context of congenital CMV infection, knowing that all babies are at risk potentially for developing hearing loss, and knowing that some babies may be at risk for neurodevelopmental disability, but also knowing that we don't have a way to identify them. We don't have a way to pick them out. Like I always tell a family with a new baby that tests positive for congenital CMV, if that baby's exam is normal and if their evaluation is normal, I always tell them, I can tell you what happens to 100 babies on average with CMV that are just like your baby. But what I don't know how to do is I don't know how to tell you what's going to happen for any one single baby in that group because I don't have the biomarkers. I don't have the biological data that helps me ascribe prognosis. So maybe saliva will help us with that in the future. That's my hope. And I think with that, I will stop and I would love to hear your questions, comments, and personal experiences.
Amazing. Thank you so much. I feel like we just got this incredible lecture from you as a professor and got to sit in on your class for that amount of time. And so really appreciate you sharing such a robust overview of CMV and how saliva-based diagnostics can improve early detection and where those opportunities exist. I'm very excited to get into the questions that got submitted before this presentation. And I see that one has already been submitted through the Q&A. Please feel free to continue posting them that way. But we do recognize we're towards the end of the hour. So if any of you need to jump off, don't worry, we're going to send the full recording of this presentation, as well as links to the feedback survey and request for PACE forms later on. So don't worry about that if you need to jump off. But recognizing we do have some great questions, let's go ahead and dive into those that came through. The first one is for you, Dr. Schleiss. How often are birth parents screened for active CMV infection prior to delivery? Could that help to focus the screening needed for a newborn?
Yeah, that's a great question and very controversial. The person to screen would probably be the mother or the mother to be. And we think that anybody who's ever had CMV in their lifetime will intermittently have an active CMV infection and be shedding virus off and on, probably for decades. It's a very strange virus in that respect. It's a herpes virus, and so it does reactivate from latency. I think in the obstetrician's mind, the individual they're most concerned about is the woman who gets the first CMV infection of her lifetime while she's pregnant, especially if it's in the first trimester. And so there's a lot of debate in the literature and in conferences and public policy workshops. Should we just test all women for CMV who come in for pregnancy care? And the American Congress of Obstetrics and Gynecology does not recommend that. And as pediatricians, we sometimes argue with them. And because I believe that if we just tested all women for it, everyone would know about it, right? And so it wouldn't be a mystery anymore, and it would be just one more thing on the checklist like cat litter and sushi. But they argue that finding that window where a woman converts from negative to positive is difficult. And they also argue that they will create unnecessary anxiety in the 50% of women who have an antibody test that's positive for CMV. So we don't really know what to do yet in the United States. I will say that in Canada, some provinces do recommend that all pregnant people get screened for CMV antibodies during pregnancy. And this is very, very commonly done in Europe as well. So it's another area of controversy with no clear international consensus.
Thank you for that. Another question that came in is, have you seen a correlation between false positive samples and other medical or genetic conditions?
Hmm. Uh, so something that might give you a false positive. Yeah. Um, I can't say that I have, but I'm glad somebody asked that question because it gives me a chance to clarify something. And I'm not a like I'm not a biostatistician or epidemiologist, so I'm always using these terms incorrectly. I'm quite sure, but to me, there's a false positive because there's something in the assay that gives you a positive result that isn't true, right? That's like a false positive. Like if you have Lyme disease, you have a false positive syphilis test, right? You don't have syphilis, but it gives you a false positive. CMV is not like that because I think these are true positives in the sense that the viral DNA is there, right?
Yeah.
I mean, you swab the baby's just gone to breast, then you swab the baby's mouth and you do a PCR and it comes up positive, and that's real, right? That's real CMV DNA that's in the baby's mouth. But the issue is that the baby doesn't have congenital CMV, right? Because you test their urine and they don't have congenital CMV. So
Mhm.
to me, that's not a false positive in the same sense that the patient with Lyme disease has a false positive test for syphilis. There's probably a word for it, and I don't know the word. And so if anyone in the audience knows the right word, please tell me. But I'm glad somebody asked that question because it gives me a chance to clarify that point. The other thing that's a pet peeve of mine for many years is I hear a lot of clinicians talk to the mouth swab as being positive because of contamination.
Mm.
I think we got to get rid of that word because the last thing in the world I would ever want to imply or suggest is that a mom who's lactating, preparing to breastfeed her baby, is feeding her contaminated breast milk. That's not the right word at all. It just so happens that breast milk has CMV in it, but that's not
Mhm.
contamination. So anyway.
Yeah. Thank you for that. Thank you for that. And the offers out there, if anyone has a more appropriate term, feel free to loop back with us and we can make sure that we get that maybe terminology sent over your way in an email, Dr. Schleiss. But appreciate you taking the time to respond to that. Another question that came through was, do you have research-based evidence that would discourage the collection of samples before the 24 hours after birth?
Before the 24 hours.
Hmm.
Well, I think a sample should be collected as soon as possible after birth.
Hmm.
So in fact, I think 20, less than 24 hours is actually the optimal time to do it. When we were doing our pilot study, you know, we were like always really excited if we could get to a baby shortly after birth before they'd even gone to breast.
Hmm.
If they had, we would try to delay at least, I can't remember what the protocol said, 30 minutes, I think, at a minimum, before trying to do a mouth swab. And as you go from colostrum to transitional milk to true milk letdown, which occurs at home, the baby's already gotten home by then usually, but the amount of viral DNA actually increases. So I think the sooner you can get it after birth, the better. Um, if a baby has congenital CMV, usually they're born with very high viral loads, that are demonstrable immediately after birth. So I think less than 24 hours is optimal. What's the upper limit? I mean, by convention, we say 21 days. We say if a baby's 21 days of age or older and they're shedding cytomegalovirus, you cannot assume that that was congenital infection. Now, if you drill deep into that literature, in fact, there probably are some babies that get a postnatal infection even as early as day of life 10 or 14. But like anything else in, medicine or science, I mean, you have to pick some parameter and go with it. So
Absolutely.
that's kind of the upper limit. But the lower limit, I think as soon as you can after birth, the better.
Great. Thank you. Thank you for clarifying that. Another question that came through is, what tips can you give for reducing false positives in saliva samples? Specifically, how can we better educate hospitals?
Yeah. I don't think the issue is education,
Mm.
because you're not going to deny a mom and a newborn the opportunity to bond and begin the breastfeeding process. I think the sooner a baby can latch and begin that process, the better. I would never, ever want to adopt any kind of policy that would discourage or delay the initiation of even those very early stages of breastfeeding. I think that if you were trying to batch and process samples, again, as I alluded to a moment ago, if you can at least get them 30 minutes or more after a baby's gone to breast, that is helpful. That will discourage false positives.
Mm.
Um, but beyond that, I think you have to just simply acknowledge that there will be false positives. Now, in my study and in most studies, we don't have a newborn infant before us where we have the luxury of knowing mom's serologic status. If a baby is born to a CMV seronegative mom, and we knew by perchance that she was still negative at the time of
Mm.
delivery, then you know by definition, that baby's not going to have congenital CMV. There might be the really rare, incredibly unusual circumstance where she's got an acute primary infection that she acquired just a few days before the baby was born, but that would be very unusual. So if we were to adopt universal maternal screening during pregnancy, and then we could use AI or some of your algorithms that you've developed that you were talking about earlier, your case management platform, for example, if we were had a way to kind of couple and combine that data so we could identify the moms that, yeah, we know this mom was seropositive and, factor that into the interpretation of the saliva PCR. If in fact it is saliva PCR that's being done, then that might be one interesting pathway to pursue.
Hmm. Jack, did you want to add to that?
We would love to do that. That
Fantastic.
is exactly the type of work that we love to do. So absolutely.
Amazing. Amazing. Great opportunity for consideration and partnerships going forward. And I see there was a related note that came through about someone who's from Florida and has a hospital who's collecting samples upon admission to the NICU, therefore often prior to 24 hours. Through analysis, those samples had a much higher false positivity rate. So there's that comment there that maybe Natasha, if there's a specific question that you want to ask, we can connect you guys via email and can work out some nuances. But Dr. Slice, if there's a response you want to offer to that, you're certainly welcome to.
Um, Breast milk false positives, or is that what she meant, or baby false positives?
It's not specific, which is part of why I was inviting her if she wants to follow up with a
Yeah,
question.
sure. I'd be glad to discuss that in more detail. The NICU is a really challenging population for a variety of reasons. I mean, one is that babies often won't get their dried blood spot test until they're older. I mean, by older, I mean like 2, 3, 4 weeks of age. And same thing with their hearing screening. There's so many complex medical management problems, especially for the extremely low birth weight preemies, that they wait until they're close to discharge before doing hearing screening. And yet breast milk is the preferred food for those babies, and nutrition source of nutrition for those babies, as it should be. But you end up with a lot of preemies acquiring CMV after birth from mother's milk. And when New York State was doing their universal newborn screening pilot project, the ways that their state set up their dried blood spots testing, not just for CMV, but for everything, they included a lot of dried blood spots that were collected in preemies at 2, 3, 4 weeks of age, just simply because that's when they were able to get them.
Mhm.
And so they had a lot of CMV, but it wasn't congenital CMV. And so that's another factor as well. And the problem of, infection and disease in extremely low birth weight preemies due to congenital, or excuse me, postnatal CMV is almost a whole talk in its own right. I think that actually might be the kind of clinical scenario where the saliva might actually be really useful
Yeah.
because, if you've got a 750 gram X 32-week preemie whose day of life 22, and overnight they crumped, as we like to say, right? That's temperature instability and their blood work looks abnormal and they get started on ampicillin and some cephalosporin. They get a rule out sepsis workup. I mean, a lot of the time that's a postnatal CMV infection.
Mm.
And so maybe, and I've said this to people over the years as well, in the NICU, the newborn intensive care unit, in that setting, you just kind of want to know, is it there? And if it is, you still want to give that baby breast milk, but you might monitor that baby more closely. So anyway, the NICU is kind of its own unique, extremely challenging population, but one where we need a better understanding of what to do.
Yeah,
Um, and
absolutely.
so that's a ripe area for future research as well.
Absolutely. And with you mentioning about saliva being a potential opportunity for that, it's reminding me of previous presenters that have come in through and talked to us about using saliva-based screening for sepsis in NICUs or in newborns and things like that. And there's some really amazing opportunities for, as you said, if you have this very, very tiny little one that has very little blood to draw in the first place, being able to use something like saliva can create opportunities that might not otherwise be as friendly to that little one.
Absolutely.
Yeah.
Absolutely. Yeah.
Yeah. It looks like we've got time for another question or two, which we have on deck here. I might have to send you through the ones that we don't get time for.
Okay.
But the next one is how could collecting and shipping saliva samples be integrated into what's already being done for heel stick blood collection for analysis at the state public health lab? Has this been done successfully?
Yeah.
There seems to be a number of logistical issues that this person would worry about.
Yeah. Great question. So, what I found, and we just made a decision when I started our screening study in Minnesota in 2016, because although we had some funding to support it, for which I was very grateful, we had to be judicious in how we spent those dollars. So we decided we would just dry all the saliva samples.
Hmm.
So every saliva sample collected in all of those newborn nurseries in Minnesota that I showed you on the map earlier, they were dried and then shipped dry. That makes life so much better because if you have to ship a wet swab where you're worried about the diluent, you're worried about the seal in the tube, you're worried about the ambient temperature and packaging
Sure.
and timing. If a bunch of dried swabs get to you a day or two later than you thought they would, okay, that's not a big deal. Um, I owe a great debt of gratitude to Suresh Bopanna and Shannon Ross, Karen Fowler, and others who really pioneered looking at this in that CHIME study in the early 2000s. They were the ones that showed that a wet saliva swab transported in viral transport media and a dried swab had the same sensitivity. You didn't lose any sensitivity letting the swab dry. So that's what we did. And that essentially was our comparator, right? The dried saliva swab, the dried blood spot, and then any test that was positive in either category prompted a workup and evaluation for congenital CMV in the baby. But to get back to the question, I mean, I think that's the answer, at least for saliva. I think it is possible to, ship these in dried uh, samples. And, has a state lab ever done that? I mean, some state labs have piloted saliva screening, but I don't know the answer to that. I can certainly ask around, and if the person asking the question wants to email me, I'd be glad to follow up with them. It is interesting that even though saliva stood for a decade or more as sort of the preferred template for universal congenital CMV screening, the three states that have done this now, Minnesota, Connecticut, and New York State, they've all used PCR of dry blood spot and not saliva. But I think that that's directly due to the fact that, again, the Guthrie card or, dried blood spot card is just a standard part of care. So you've got the material there in front of you. By the way, I do want to mention that Dr. Guthrie, the father of newborn screening, the person who developed the test for newborn PKU, phenylketonuria, was a graduate of the University of Minnesota. So
Add that to the
I
reasons
had to
why
throw that in. Yeah.
it's the standard of care, of course, absolutely, for your region. So I think we might have time for just one more question. And so for those of you that have additional ones coming through, please feel free to contact us and we'll make sure to get those over to Dr. Schleiss for answering. But just with the little bit of time that we have left, you spoke of the time, travel, and other costs associated with screening. And for those states that don't have universal screening programs like Minnesota does, where do you see the biggest opportunity for improving access to improved screening? Is it the pooled samples you recommended? Is it taking political action like you all did? What do you see as being an avenue?
Yeah. What a great question. I sometimes will have a conversation with a legislator in St. Paul, and we'll talk about the newborn screening legislation and so forth and so on. And they'll say, "Now, remind me, you finally got that passed. It took you what, 7 years?" And I'm like, yeah. And they'll say, how did you do it so fast? And so just to give you an idea of the different time scales, and as physicians, we want results now, and so you have to kind of recalibrate your sense of time. Um, to the question, I think the landscape has changed in so many ways just in the last 3 or 4 years.
Mm.
And quite frankly, one of the biggest issues for us in getting that legislation through was the COVID-19 pandemic. Like, what? How does that work? Right. And so I'd like to think that it was a better sense of public health and, you know, diagnosis and application of science to the care of children and so forth and so on. I'd like to believe that that's the reason. But the reason was just good old fashioned money.
Mm.
The COVID Relief Act passed by the Congress in 2021, 2020, whenever that was, states were flush with cash. I mean, we had a budget surplus in Minnesota of, I think, maybe $8 or $9 billion or something like that, and as most states did, and
Mm.
and so that made getting that legislation passed so much easier because
Yeah.
the cost of actually doing the PCR is trivial. I mean that the test costs, you know, $6 or something. I mean, it's that's nothing. The real cost is the infrastructure, the counseling, the data collection. Every baby that screens positive it needs to be discussed with the family, the primary care doc. It's a lot of money, and I think that the landscape today politically would make that harder to do because most states are now fighting, over budget deficits and some real challenges. When you read that question, the first thing that came to my mind, what would make the biggest difference right out of the gate? I think education of physicians that are
Mm.
discharging newborns. And one thing that came up with universal newborn congenital CMV screening was this idea that, hey, the babies you really worry about, right? The babies that really need special care and are going to really have issues, you're going to identify them. You're going to do a physical exam and you're going to see that, oh my gosh, this baby's got a problem. This baby's got microcephaly, or this baby's got an unusual rash, or this
Mhm.
baby has, an abnormal neurologic exam. We, we aren't going to miss those. Well, the answer is we do. People discharging physicians, discharging babies in the newborn nursery miss these clues. And I don't mean that as a criticism or disparaging remark at all. It's just stuff happens. And some of these findings are subtle. And I can't tell you how many times we get back a positive newborn screen and go back and look and say, oh, wow, you know, I'll be darned. It all kind of ties together. There was evidence here that something was going on. And
Mhm.
so I would say, so what some states have done is, and in my review article that I had in one of my early slides, what kind of screening should we have? Universal screening, targeted screening, enhanced targeted screening, or none at all. I think that's the title of the paper, more or less. Anyway, the concept of enhanced targeted screening has emerged. What does
Mhm.
that mean? Well, targeted screening has always been the idea that if you fail the newborn hearing screen, those babies are at an increased risk of CMV and they should all be tested in the newborn nursery. Somebody came up with the idea, I think it was actually Albert Park at University of Utah, pediatric otolaryngologist. Enhanced targeted screening is other subtle findings in the newborn period. The baby is small for gestational age with no clear explanation. The baby has got a petechial rash. A few other, sort of subtle things that just aren't quite right. Um, you, you know, those babies should be tested for congenital CMV as a standard of care, right? So you don't need a funded newborn screening program to do that. You just
Yeah.
need better physician education. And so I've spent a lot of my time over the last few years, going to small community hospitals throughout Minnesota, talking not only about my studies, but also, how these babies present.
Yeah.
And so if you don't have a legislature that's proactive, if you don't have a budget surplus in your state, if you don't have a newborn screening program that is ready to pick up this ball and run with it, that is something that can be done at, in CME, hospital conferences, committees, and any physician who practices in a community hospital knows that there's plenty of committees to sit in on. So that might be an opportunity that's, doesn't need a large $1 million grant, but that could pick up a lot of these babies because they do get missed. And that's one thing we've learned from universal screening.
Thank you. Thank you for that. And thank you for giving that opportunity for reflection on where we can make a difference, even if there aren't necessarily the right environment or circumstances or funding to make something bigger happen. I appreciate you flagging that. And really appreciate so many of you sticking with us and joining us for so much of this time and hanging out a little bit after. Really appreciate Dr. Schleiss, you sharing this information with us and sticking around to answer these questions. Very excited to see what kind of connections and ideas will come out of this.
Thank you all. Thank you.
Thank you.
Thanks, everyone.